Welcome everybody to the CGEC speaker series for March. Today we have a very special guest who is currently abroad, but still kindly making space for us. My pleasure to introduce Professor Gil Burnham. I think it would take at least a half hour to properly present his experience and accomplishments, as many of you know. So I'll just say instead that it's hard to find somebody active today in global health emergencies who does not directly or indirectly owe a portion of their training, mentorship, and or skill set to Professor Burnham's long work in teaching and advancing the field. And so thank you for that, Professor Burnham. Many of us here today, including myself, count ourselves lucky to have been eager young graduate students in your classes. And today we have the pleasure of learning, I believe, a little bit more about your path and also about a very interesting active project. So without any further ado, Professor Burnham, I'll turn the mic over to you.
All right. Well, thank you very much for that introduction. And this is one of the advantages of having lots of tree rings. You've had lots of students over the years. And while I've been here in Gaziantep in southern Turkey, I run across about four people who've already were my students at various times. So anyway, it's always a nice time to look at this kind of thing. So one of the requests was to talk about my kind of entry into the global health arena. And this is a really looks like a zigzag kind of skin of a zebra kind of thing. So there, I never saw any great trip from A to B, but I went through various ways. And I might say that I got my start in global international interests because my parents were having a vacation in Mexico, and my mother got pregnant with me in Mexico. So that was kind of my start of my international exposure. And I had a really interesting family because on my father's side, there were a lot of left-wing, in fact, radical left-wing people, but they had one thing in common. They all worked in international programs and UN and so forth. And my mother's side, they were a very devout religious group, and there were lots of missionaries, and they worked overseas in many places. So you kind of grew up knowing that globalness was someplace in your future. You didn't know where it was, but it was just going to happen someplace along the line. So I did history as an undergraduate, and that was a really great preparation for global studies, because you can see how borders moved around and why people are where they are at the moment. But then at some places, undergraduate, I discovered that as interesting as history was, I couldn't really make a living at it. So I had to think about a plan B, and somehow at the last minute, medicine came up as a plan B, and wow, that was a great idea. And I did my medicine in California at Loma Linda University, and I went there because that's where all my uncles and cousins and everybody else went. So you just thought that was the kind of family medical school that you went to. So I went there, and that was great. Then after I graduated, I had a 1-year residency, and those were the last days of the war in Vietnam. And I got drafted at that point. Now, that was probably okay because I didn't have a clue what I wanted to do. I knew there were a lot of things on my list that I didn't want to do, but I couldn't figure out what it was I wanted to do. So as luck was it, I went to Korea instead of Vietnam. And wow, that was a fascinating experience. So if you had history as an undergraduate and you went to Korea with this amazing culture and history that goes way back to, you know, the mists of time, it was a great experience. And while I was there, it was an interesting experience because I had always registered for the draft as a conscientious objector. Not that I had any really deep feelings, but I knew that whatever I did, I didn't want to go shooting people. So when I was there, my medics in my medical platoon, they were all conscientious objectors as well, for various reasons. And so we got permission from our commander to start doing mobile clinics. And in those days in Korea, it was really a primitive system. There were no hospitals or clinics any place around where these army posts were. And at that time, probably North Korea was more advanced than South Korea was. So we had a great time. And it was really satisfying. We'd find people with injuries. We had a lot of burns. And of course, the Army had lots of good medicine for burns. So, but we didn't have any beds. So we'd send the ambulance out to the village in the morning. We'd pick up the person with burns, bring them in, change their dressing, give them 3 or 4 liters of IV fluid all day, and then take them home again at the end of the night, end of the afternoon. So at some point I thought, I wonder if you could make a living at this. This is really pretty interesting stuff. So maybe that was another kind of interest in this area. So I stayed in the Army because I had an opportunity to do my internal medicine in the Army, which was very interesting. And I started getting interested in parasites and the various things that cause tropical diseases while there. And I had an opportunity to do a 4-month, 5-month elective in my medicine residency. So I went to London to the Hospital for Tropical Diseases and spent that time doing a lot of clinical work in tropical medicine. And that was really great. And then I went back to the Army. I had another year and I was posted as a deputy hospital commander. So I learned about running hospitals and I found this is really interesting stuff. So the whole idea of hospital management was really quite interesting to me. And then at that time, I decided I wanted out of the Army and I wanted to go to Africa. So I had the bug to go to Africa. And along the way, I decided, I have this GI Bill, so I'll go back to London and do a master's in tropical medicine at the London School, which I did, and it was a lot of fun. And then I got a job with an NGO hospital in Ethiopia. But before I got to the hospital, it was during the communist era there, the Army took over the hospital. So I never got to this hospital in Ethiopia, which was a disappointment because I had studied up on all these tropical diseases in Ethiopia. And wow, there's some great diseases in Ethiopia if you're a clinician. And so that was fascinating. So then instead I went temporarily to Zambia, and then I got a job at a NGO hospital in Malawi, where I was for 14 and a half years. And that was a great experience. It was not really sustainable in the long term because I was just on a local salary getting a few $100s a month, but I could get by on that. My wife and I managed okay. And I got interested in onchocerciasis because river blindness, this was a disease that was present there, but nobody had ever done the epidemiology of it properly. So I just started off putting pins in the map, and then I started doing more stuff. And pretty soon I got some money from the tea planters because the tea planters believed all of their employees were infected and they weren't plucking enough tea. And if somehow they get rid of the disease, then they could pluck more tea and there'd be more profit for the tea industry. So of course I played shamelessly on that, got a little resources to do the epidemiology of it. And this has always been a hobby of mine in this area. And I was in a position where I could start one of the first clinical trials for ivermectin, which came along because before that there was hardly any treatment for it. And I've continued with that. I'm now chair of the Mectizan Expert Committee for the last many years, looking at the management of onchocerciasis in about 29 countries in Africa. But now we're doing lymphatic filariasis, and we have another 100 million people involved in those programs. So this has been a very rewarding job. And along the line, onchocerciasis is almost totally gone from Malawi. And this is a terrible itching skin disease as well as blindness. So that was very exciting. But one of the things that really interested me was leprosy. And if anybody's had a chance to look at leprosy, wow, this disease has got everything. It's got immunology, it's got neurology, it's got dermatology, it's got psychology, it's all there. And I got involved with this leprosy control program because they needed to have some medical consultant to help them with managing the leprosy complications because they were mostly just administrators running the program. And into this area where we were doing leprosy, and we were doing it with a kind of a DOTS treatment at the time, into this area came 300,000 Mozambican refugees from the war in Mozambique. And many of them had pretty bad leprosy, but wow, this was an interesting political situation. And the whole management of refugees was a fascinating kind of area. So I got really interested in that. And we got involved in other conditions there as well. So this is a good opportunity to look at the leprosy control as well as the refugee situation. So after about 15 years in Africa, I thought maybe it was time to come back to America. And it was nice in Africa. I really enjoyed it. And we got leave about every 3 or 4 years. So we'd have 3 or 4 years there. We'd come back for 6 months to the US and then back there again. So that was enjoyable. And I looked around at various openings, and there was an opening at Hopkins. So I applied to the program at Hopkins, and I got a position here, and it was basically to do quality assurance. There was a big quality assurance program going on, and there were many faculty involved in this, and that was my start. But when I did the job interview at Hopkins, one of the faculty asked me, they said, by the way, do you know anything about refugees? The students are really interested in refugees, but faculty don't care about it. And I said, yeah, I've got an interest in it. So we started some programs in refugee health. And one of the students in the first year, which was about 1997, I think, or yeah, about 1997, he's here in Gaziantep right now, and he's head of disaster management for all of the Eastern Mediterranean region in WHO. So some of the students have gone on from Hopkins and done really, really good things. So that was kind of my focus there. And then in 1998, I set up the center, which is now the Center for Humanitarian Health. And then we've done a lot of other interesting things. I've worked in Afghanistan for 18 years on projects. We've done 20-some papers from Iraq. I'm involved in Yemen right now. We had some interesting stuff in Libya. I worked in China with the children of trafficked North Korean women into China and helping the local NGOs there manage those. Then I've done a lot of interesting teaching. In addition to Hopkins, I teach a course regularly at the National University of Singapore, which is interesting, and also another disaster course at the Yonsei University in Seoul. These last few years, we've been virtual, but I think we'll be back to in person here fairly soon. So just to finish off on this long kind of ramble here, people ask me, what is the most interesting thing I've done in my whole life? And I would say when I was in Malawi, for 4 years, I was the personal physician to the president of Malawi, who was a dictator, but a physician and a very interesting dictator at the same time. So we had a lot of really good conversations in his palace at various times. So that was a fascinating kind of thing. And I got this job because one night, and I was about 45 minutes out in the country, I got a telephone call and it said, come to the palace immediately. So, in the Middle Ages, if you got summons to the palace, that was not a good sign. But anyway, my wife was quite worried, but I went to the palace and I found the president in acute pulmonary edema, and I got him out of acute pulmonary edema. And ever after that, I was his doctor. So it was an interesting experience for that. And then people say, what's the most depressing place you've ever been in your life? And that's not hard to say. It is the 2 times that I've been in North Korea. And that was a really depressing place. But for me, it was great because at the end of being in North Korea for a week or 10 days, you could do what 22 million North Koreans wanted to do but couldn't, and that's get on the airplane and get out. So that's about what I've done there. So a lot of interesting things. Nico, should we take any questions or comment, or do you want me to go on and talk about what I'm doing here in southern Turkey at the moment?
Yeah, I think if you want to go ahead and you could share the screen, and okay. While he's doing that, if anyone has any comments and impressions, feel free to shout out or put in the comment box, and I can highlight them if Dr. Burnham.
Okay. All right, so I can say in my background picture here, I have a picture of a big UN convoy going across the border from southern Turkey into Syria, and this is the last of the one-time many cross-border places that the UN can cross. NGOs can cross in other places, but this is the only place the UN can. All right, let's see what I can put up here. Yes, let's see, I've got to the Uh, okay, let's start at the first here. Okay, so I'll tell you what I'm doing here in Turkey at the moment. And this has a lot of really interesting ramifications because as many of you know, the humanitarian disease world has changed a bit because in the old days we were dealing with outbreaks of malaria and cholera and typhoid and all those kind of fun diseases. But these days we're dealing with insulin-dependent diabetes and hypertension and unstable angina and various other things. And one of the issues that was a big problem inside northwest Syria, and this is an enclave of about 4 million people that's controlled by the opposition faction and really hasn't been conquered by Assad and his Russian colleagues. One of the big problems there is people on hemodialysis. And there are about 700 people on hemodialysis in this part of northwest Syria. Now, the population is a bit different than we might see in other places because these are all not people on disability. These people are working. They have to scrabble to support their families. So this is an important support for families to keep this going. And I'll say a little bit about it. Here's a little bit about the background here. Before the war in 2011, there were a couple things going on in Syria as a whole. There was a fair amount of renal transplant going on, and there was hemodialysis. But after the war started, we don't really know what's been happening much in the government areas, which is about half of the country now. And there are two non-government areas. They're the besieged areas, and these are the ones that are under constant conflict. And we know that where the hospitals have been destroyed and other places, the mortality rate is really high. There's a big problem with mortality in these areas because people just can't get the dialysis. But in the non-besieged areas, or more correctly, kind of the low-level conflict areas in the Northwest, there are a number of them have closed because of lack of funding. Some of them have been destroyed or they've been occupied for the services. And in one center, 17 out of 35 people had died from lack of access because there just weren't any supplies after the military had destroyed things. So basically, what we have now is someplace between 3.4 and 4 million people. And of those, the majority are internally displaced. So they've come there from other parts of Syria. And somewhere around 700 are on dialysis. Now, most places will try to do dialysis a minimum of 2 times a week and preferably 3 times a week. But the resources are such that nobody can seem to do more than 2 times a week here for various reasons. And some of these areas are subject to bombing by the Russian forces and the Syrian regime. So basically what's happened is they tend to move. So we have kind of a lot of small facilities that are in buildings or storefronts or other areas. And there's just a few of them that are big ones and are based in the hospitals. So as I mentioned before, there's a lot of need for this because people need to work, and this is what keeps them alive and working. Now, there are 21 dialysis units in Northwest Syria, but as some of you might remember, a couple of years ago, the Turkish forces invaded northern Syria because they wanted to stop the Kurds who were working in this area. And in the process, they picked up about 6 or 7 dialysis units. So some of these are providing services to the Syrians, but they're being run by the Turkish military. And then there are 14 that WHO is trying to coordinate and keep going. So we got into this, here's our problem statement, that the conflict and lack of support has resulted in a high rate of infection and poor services among dialysis patients. So WHO has been nominally supporting the dialysis program, but they've been really unhappy about the quality of services. So they reached out to somebody who reached out to me and said, would you be interested in taking on a program to improve the quality of dialysis? And as a somewhat inactive internist, I thought, wow, this is a great opportunity. It's exactly what I'd like to do. And searching around in the kind of Hopkins network, I found a nephrologist at the hospital who was a Syrian and a very fluent Arabic speaker, did his medical degree in Damascus. And so he was keen on that. So the two of us have been working on this for the last 6 months. And I'll tell you a little bit about the background and about some of the things that we've been doing. Now, in case Syria is a bit fuzzy exactly where it was, this is exactly the situation that Ukraine was in until a few months ago. You can see the red dot on the map here on the Eastern Mediterranean for Syria. And you can see the blue dots. These are the people that are requiring assistance from the UN system. So a lot of people in rural Damascus and Damascus area still needing assistance, but these are in the government controlled area. And so that is channeled through many of the agencies that are based in Damascus. But up in the northwest area, Aleppo and Idlib, that's where the largest number are that are dependent on cross-border assistance. So that's the ones that we're focused on. So if you're kind of rusty on your geography, Turkey is along the north, and that red circle is where I am right now in Gaziantep. The added feature of Gaziantep is that it's the center of the Turkish pistachio nut growing. So that's always a pleasant thing for coming here. And then you can see that we have Iraq on the right-hand side, a large part of the border with Iraq. This is a big problem because ISIS went back and forth across the border a lot. To the south is Jordan. Jordan has large numbers of Syrian refugees. There's a little narrow area with Israel in the Golan Heights, and periodically there are missiles going back and forth there. But interestingly enough, there's a fair number of ill or injured Assyrians that make it over the fence into Israel, and Israel has a kind of unofficial aid policy of providing assistance to the Syrians that can make it across the fence into the Golan Heights. And I had a student in a summer course, and this is what she did, is ran this program for the Syrians in northern Israel. It was a fascinating program. And then, of course, we have Lebanon, and 1 out of 8 people in Lebanon now is a Syrian refugee. And if you go back far enough before the French occupied occupied Syria and Lebanon after the First World War and after the Ottoman Empire was broken up, Syria and Lebanon were the same country. So there's a long history of connection back and forth between these. And Lebanon, of course, as you know now, is an economic basket case, and then they have the refugees on top of it. So this is really a terrible situation in which one can find themselves. Okay, that's enough about this kind of map. Here's a map that looks at the people in need, and the darker colors on the left are the larger number of people. So a lot of people up in the northwest where we've been working, but some in the Kurdish areas in the center north and then to the far northeast. But then if you look at the severity of need is actually strongest in these areas that are most remote and more difficult to reach. Not surprising, that's a common humanitarian issue that we have to deal with. And here's another map here showing the areas that are controlled in green by the opposition parties. The blue areas are the areas that are occupied by Turkey. And these are mostly Kurdish areas. And as you know, the Kurds have not been always on good terms with the Turks, both inside and outside. So there's some tensions going on there. So I just mentioned that the NGOs have taken over the dialysis units, and there's a number of them, including the Syrian American Medical Society, which is a very active organization in the US. In 2019, there was a report showing things were in bad shape, and that was the kind of predecessor to us getting involved in this. And it's both in quality control and infection prevention and control where the major areas are. Although, as we found, there's a lot more problems as well. Virus infections are widespread, the staff get them as well. Maintenance of the equipment was uncertain. Some technical staff were good and some had problems. So it was a lot of indifference there. And many of these dialysis units were being taking place in uncertain circumstances with people of questionable skills, or maybe they had a lot of experience, but they didn't have a lot of training. So there's a lot of concern about that. And these dots are the areas where there are the dialysis units. And the big red dot is the main one at the Idlib Health Directorate. And it's the only one, I think, or only one of two that's still part of a hospital. The rest of them are all kind of freestanding dialysis units with variable number of patients being seen. Here's a little
أنا محمود أبو
video.
رشيد
It
من
gives you a
مدينة
background
حمص،
about
مريض
things.
كلي ل 17 سنة، بغسل كلي، بغسل مرتين بالأسبوع. بحمص كنا بحي الوعر وتحاصرنا بحي الوعر، وأمورنا صارت صعبة كثير هنيك، ما نقدر نجيب مواد، ما نقدر يعني كل الجلسات تكون مأمنة. قدرنا نطلع من حمص وجيت على إدلب على معرض النعمان.
مركز غسيل كلي في معرض النعمان يقع في مدينة معرض النعمان، تغطي ريف إدلب الجنوبي وريف إدلب الشرقي وريف حماة الشمالي. تخدم منطقة حوالي 400,000 نسمة. لدينا حوالي 50 مريض غسيل كلي شهريا، بيجرون حوالي 500 جلسة في الشهر.
هون الحمد لله يعني أمورنا منيحة هون وخير الحمد لله رب العالمين. يعني المشفى مأمنتنا المواد، مأمن الغسيل، عندي جلستين بالأسبوع والحمد لله المواد متوفرة. يعني
دعم السامس مركز غسيل كلي في المعرة منذ عام 2015 وحتى الآن قدمت ما يقارب 25,000 جلسة. طبعا المركز الوحيد في المنطقة هي أهميته كبيرة، حجم الجلسات شهريا ومكانه اللي بيتوسط المحافظة جنوب.
All right, that's a little promotional film from Sam's, but it's a good indication of what's going on. Now, among this nearly 4 million people and in the population, in the 700 people with dialysis needs, there's one full-time nephrologist and there's one partially trained nephrologist. And most of the centers will have access to an internist that has at least some knowledge about dialysis, but many of them don't even have that on a regular basis. And even the people that, even the places that do have a nephrologist available, this is only a drop-in visit once in a while. And it's not a on-site support in any way. So a lot of issues there. So here we are at the Gaziantep office, and there's Tedros on the computer screen. We're all there in person, and I have on the extreme left is the head of the office, Dr. Mahmoud, is a Palestinian. Mahmoud and myself is Dr. Sami from the Department of Nephrology at Hopkins Hospital. So WHO plays a big role in this. They're supporting this. Sometimes they provide supplies and equipment, but they try to at least keep the systems working and people talking to each other. That's kind of the communication center for emergency response in this area of Northwest Syria. So this is the plan that we put together for improving the quality. So the first step we did was to assess the current status of hemodialysis. So if you've ever done any quality assurance, you know you start with basic numbers. You need to find out what the current situation is, what the available resources are, and the challenges and so forth that the systems face. So that's where we started off. And there had been some data from a few years ago, but we started off collecting data on our own. And then we identified what's known as the performance gap. What's the gap between the present performance and the desired state? And here we're talking about desired or optimum state. We're not talking about maybe American standards or European standards. We're trying to see what is the maximum, what's the best level of services that can be provided in this situation where water comes and goes, electricity comes and goes, bombs come and go, and so forth. So what can you actually do that's feasible to close this gap? And then once you've done those kind of activities, then one puts together a monitoring system to be sure that you can sustain whatever gains you've made and that you have problem-solving capacity in place. So if new problems come up, these things can be dealt with. Now, there's a side issue as well that rather interests me, and that is this is obviously a major non-communicable disease problem for many people, although it's not a high prevalence in the community. However, there are some probably good lessons in this that could be applied to dealing with other non-communicable diseases in humanitarian situations. And this is one of our real problems because we put so much of our effort into primary healthcare over the years, and we've got a lot of results. We've got extended life expectancies. We have reduced maternal mortality ratios. We have lower infant and childhood mortality. So we've done a lot there, but how do you integrate non-communicable disease management into a primary healthcare system? How does the primary healthcare system deal with people who have insulin-dependent diabetes, for instance? So a lot of these kind of challenges that we have to face. And I like to think that there's some lessons we can probably learn from the way that we address this problem with dialysis that we could apply to other situations as well with non-communicable diseases. Okay, so what we did was to develop a task force, and WHO supported the task force, which was a group of the managers from the various dialysis programs. So we came together to plan out what we were going to do, and lots of ideas in the beginning, and lots of considerations about various options and what are the resources and the usual kind of things. But we set out to do a problem identification. Now, some of you who've done quality assurance know that one of our tools that we like to use is called the fishbone. And this is kind of a problem identification. It's kind of an organized brainstorming situation. So people identified the problems and they put stickers on the wall. And we moved the stickers around until we got them more or less organized. And here's the fishbone with a little bit of reinforcement here. So on each of the fins, dorsal fins and ventral fins, there's a group of problems that are related to each other in some way. And the head of the fish is the problem that we don't have the dialysis that we'd like at this point. So we tried to organize our planning around what were identified to be the major problems in this fishbone. Here's my friend Sammy up here reviewing the fishbone. And here's our group of dialysis managers. Now, these are not physicians. So the physicians and the nurses and others are inside Turkey, or inside Syria, and it's hard to get back and forth across the border. But all the NGOs that support the dialysis programs inside Northwest Syria have their office here in Gaziantep in southern Turkey, because that's where the donors are, that's where the coordination is, and so forth. And even if the WHO is forced to close its offices here by the Security Council resolutions supported by Russia and perhaps China, there'll still be a lot of NGOs going on here. So that's probably not going to change. But here's the group. And fortunately, Sammy, after he immigrated from Syria, did not forget his Arabic. And so we could conduct these conferences very, very nicely in Arabic. You know what? Went really very well. So our phase one was to get an assessment about what's going on. We looked at infection prevention and control. We looked a lot at quality. We looked at the environment that services were being provided. We looked at the healthcare workers themselves, what their training was, what their continuing medical education was, which is like nothing, and what are their competencies. We looked at the equipment, and as you know, dialysis equipment is fairly complex, and so how was this looked after? We looked at management and leadership, and then we looked at where were the barriers. I should add in there, we looked at the lab capacity as well. And one of the major barrier areas was to get adequate lab support for situations. And we had this amazing questionnaire, far too many questions, 500 questions, but we got a thorough picture of everything that was going on. So this was really very, very useful. So I'll share a little bit about what we found. So half of the facilities had no IPC programs present at all. Slightly more than half had IPC training, but this was kind of general medical IPC training, and only a small number had IPC training focused on dialysis. So right away we have a problem, and majority, the largest group is people had no training whatsoever. So got a problem right there. And then we looked for medical protocols. What do you do for this? What do you do for that? And as we all know, anything complex like this needs to have protocols and operating procedures and guidelines and various formative materials. And half of the people had nothing. And then those who had it, we asked about, have you ever had any training about how to use the things that are listed on page 35? And less than a quarter had any kind of training. So we had a major deficit there as well. And then we said, how about care plans? Do you have a care plan for the patient? What's the ideal hemoglobin? What's the ideal weight? And so forth. And slightly more than half had a care plan. But then we said, have the patients had a really comprehensive assessment? Have they had a full physical examination? Have they been examined for virus infections and so forth? And so only slightly more than a third had those in place for their patients. So we got a problem there as well. And then we looked at the machines and wow, only about a third of the machines had any kind of maintenance at all. And complex machinery that it produces results that people depend on for their life, not getting maintenance, well, we get a bit worried about that. And then we looked at the water system, and as you know, we need to have good water supply for dialysis, and there wasn't much maintenance at all going on there. I could show you pages of data, but these are the kind of graphs of it. And then we looked about training records. So the people who said, well, we're doing IPC, have you ever had any training in IPC? Oh, less than a third had training in IPC. And the same thing about, how about the staff health status? Do we know if the patients have been infected with hepatitis B or HIV? And do we know your hepatitis vaccination schedule? Well, not very many had that as well. So we had a lot more of these, but to focus on this, we used what's known as the classic gap analysis, looking at what the performance gap is. So between where we are now, and as we see here, we're very much down in the weeds, and how do we get up to where our desired state is? And we are still in the process of defining desired state. And that's something we're going to do in workshops this week is, what's the maximum that's achievable when your dialysis unit is 50 kilometers from the laboratory and where there is limited capacity for further internet connectivity and so forth. So we got to figure out this performance gap and what is it we need to do to close that gap. And if you've done anything with quality assurance, this gap is not usually one big thing. It's a lot of little things. So we have to look at what are the priorities for attacking these little things and which ones may have big contributions and which ones may not be so important in closing this gap. And things that we always stress is this is a continuous process. You do this, then you do that, then you do something else, and then gradually the gap closes. It's not very often that you can do one or two things that produce a dramatic result at the end of the day. So in our last workshop, we worked hard on how do we get from A to B. And one of the things we had to convince the people is this is not going to happen. No magic fairy is going to come along and make it happen to move from A to B. So what is it we need to do? So what we did is introduce what's known as a theory of change. So we have to do this, and then we add this to it, and further we add this to it, and then we do this, and we build on that and do that. And then eventually we get our results. So one of the things that we did in our last workshop was we produced this kind of theory of change work plan. And everybody had to do this for each of the problems that were identified as priorities. So there are various assumptions and there were facilitators and various things that could make them accelerate a bit more, but they had to work through all of this for a work plan to move in the direction that we wanted to go. And here was the team busy doing their theory of change and their work plan on solving the various problems they have. It was a very productive session, and we want to do this. We don't want to do it ourselves because we can get the people to do it themselves at the end of September or August or whatever it's going to be. So this was very important to get everybody into this on the same page and doing the same kind of thing. And so from this, we started creating a curriculum. And this curriculum is something that we've dealt with based upon the results from what people had told us in their theory of change, and also what we found on our assessment. And we've had some really great volunteer nephrologists. And we've had some in France, we've had some in the US, we've had some in Turkey. And these are people who are doing some training on pro bono on their own. And so here's a team inside Northwest Syria actually doing face-to-face training. And this man with the pointer in the upper photograph is the only nephrologist for 4 million people. And he was very generous with his time to be able to spend a lot of time with training sessions to try to get people up to speed. And most people had not been in a training session for many years. So this was a new experience to get brought up to speed. And it was very good to share experiences with each other in a very interactive session. And then we did a lot of virtual sessions, and we had a number of nephrologists in the US, and we had some nephrologists in France. And they did a series of these lectures, and we're in the middle of it right now. And one of the things we're going to do in this workshop is to try to assess where people have gotten with this training. And then we had quizzes and exams. So, you know, we have data on people and what they've done and what they've learned in this process. So where are we now? Well, we're about 60% through the training. And our first priority has been the IPC training. And we're about ready to close that part out and move into the medical quality part of things. So we're looking at the training now and seeing what kind of running repairs need to be done, where we've missed some things, where people think we should circle back and cover some topics a bit more. So that's what we'll do. And we're also going to start with our next phase of training after the medical quality. So one of the key things is to look after these machines. They're all more or less the same brand, Fresenius. They have slightly different characteristics. Some are assembled in Germany and some are done in the US. But the key thing is they've had very little in the way of maintenance. We have to be now cognizant about laboratory support, because it turns out that many people don't even have routine BUNs done or don't follow their hemoglobin adequately. So a lot of just basic stuff needs to be done. Never mind some of the nicer things we'd like to do, but just the basic things we need to do. And then finally, the record keeping, because certainly record keeping in the facility for the patients is crucial to be sure that we're tracking patients and we can see their trends are being managed appropriately, but also record keeping for machinery maintenance. And a lot of the machinery, we don't have any records about what's the situations when the last time various parts were being replaced. And we don't have any records about the quality control on the water from the water system either. So we don't know what's happening there. So those are our kind of next phases that we're going to go through. So what's our desired outcome? Well, we want to provide services which are achievable. And I like to use the word optimum. It doesn't mean maximum. It means optimum. It means this is probably the best we can do with the priorities and the resources that we have in an unstable and conflict-affected population. So we're not going to produce a JHU gold standard, but maybe we can produce a Syrian gold standard, if maybe not gold standard, at least a nice aluminum standard that can be representative of what we can achieve, that's feasible, as I noted here, realistic, attainable, and supportable with accessible resources. And when one considers that each dialysis session probably costs around $100 in basic materials and some resources, this is a fairly substantial investment, but these are people's lives that depend on it, not just for life itself, but because they're actually supporting their families and their community. And we want to be sure it's evidence-based. So data are very important, and a goal probably a little bit later than the facility record keeping is going to be a regional record keeping process that can be loaded up with on a web page. So the central task force can monitor things electronically, but also can pay regular visits in a supportive supervision ways to be sure that what we've attained with the initial sessions now can be sustained through the project. Okay, so this is the last picture. This is where I am right now, Gaziantep. And there's a castle in the middle of Gaziantep. And some of the foundations go back to the 3rd century BC. Part of Gaziantep used to belong to Syria, and then the border moved back and forth as well. So a long history in this area. And it was a very important trade route. Back when the trains ran to Baghdad, you could ride on one train all the way from Istanbul to Baghdad, going by Gaziantep. So very interesting historical location. So that's about what I have to say about what we're up to in Gaziantep and where we think we're going with this. And just to say, I think we're making reasonably good progress, and I'm really happy for what we've achieved. All right, so that's what I have to say.
Thank you very much, Professor Burnham, for sharing your path and presenting this very interesting project. I think it also reminds us of the catastrophe that remains in Syria now that our collective attention and the media cycle seem to have moved well beyond. Let's open up the floor to the audience. We have a few minutes here for some questions. Feel free to unmute or raise your hand, however you want to go about it.
So maybe a comment more than anything else. You know, when I first interviewed at Hopkins for fellowship many, many years ago, like over 10, Gil, I saw your office. And I think it's because you interviewed me that day, and I was extremely flustered. And then around you, this beautiful office are all these books and memorabilia and, you know, just like photos and things from different countries. And, you know, hearing you today was the first time I really understood like the true breadth of your lived experience. And I think, you know, while technical knowledge and implementation is really important, you know, it also struck me as you were talking that a lot of this work is done on personal relationships. You know, you describe Sammy as my friend Sammy, and that is how we get things done. So that was the first part. I think, you know, you're so magnanimous and so kind and so willing to collaborate. It really shows that you've cultivated a number of relationships throughout your life. The second thing I was going to comment on was a thank you, because I think you somehow took like a whole MPH degree and distilled it into 30 minutes as you used the dialysis example. But it really shows that, you know, you gave us a primer on all those different steps of how to support implementation. And that process is recreated for much of all of our work and many other projects across the institution. So, you know, there is no rocket science. It's really about doing work thoughtfully, and it's also good partnering. So thank you so much for like a really thoughtful presentation today.
Bhakti, thanks very much. And I think that what you've highlighted or you've alluded to is basically how many of us who were clinicians got into public health. And, you know, I value my clinical training enormously. This was a wonderful basis for public health. But then you realize at some point that, you know, even if you were the best internist in Africa, you know, on the bigger scale, it wasn't going to make much difference. The issues that you had to deal with were some of the social determinants, some of the environment, the water and sanitation, the health literacy, and so forth. So it was a much broader area. And so you thought, okay, you know, I need to take the next step here if I really want to be effective. And so I'm sure that anybody who's done any work in public health has come to that point someplace in their career. Okay, comments, questions people have? Valerie, I see your face is animated there, so I think that there's a thought shaping up on your face. Do you have something you want to say?
I was honestly just remarking at Jordan's comment about the tree where they threw the people with leprosy in.
Yeah. Yeah, this is an interesting situation in leprosy, which has a great history in itself. And it came into Europe in about probably the 14th century, and it devastated Europe. And you can go to some of these churches in Denmark and Norway and even in UK. And the churches took in the lepers just out of humanity. And some of the old churches have these little windows that the lepers could stand, on the other side of the window and watch the service going on. And if you look at the graveyards in these old leprosariums, the changes in the bones are exactly what we see today. So it's the same kind of disease. Although any of you who were Bible students know that there was a lot of leprosy in the Bible, but people have looked at that and, it's a bit confusing. There's probably a lot of other skin diseases in there as well. But it's fascinating. And that's how in Africa, many of the early missionaries got involved in leprosy for exactly the same reason. People got turfed out of their villages and left to die. And they felt, we should do something for them. And they took them in and they gave them lots of food and dressed wounds, but no kind of medicines. And a lot of people got better just with that.
Could I ask a quick question about the Syria project?
Right.
You mentioned the 700, about 700 patients who have established end-stage renal disease and need this dialysis to survive. To me, to some extent, I started to wonder if this was just the tip of the iceberg. And I wonder if there's been any effort to assess or quantify or approach the potential backlog of patients who have, over the last few years of the conflict, developed end-stage renal disease and do need dialysis, but they haven't seen a nephrologist to refer them. They haven't seen a vascular surgeon to establish access. I wonder if there's this huge hidden demand out there, and these 700 are just the tip of the iceberg. But it might be too frightening of a thought, I don't know, for a program that is really just getting by.
Sure, you're right. And with one nephrologist, 1.5 nephrologists in the country, there's not going to be the capacity to do much screening. And many of the basic lab tests like creatinine cannot be done regularly in many of the facilities. So the ability to screen is not very good. And we also found with the patient records, there was no clear indication of when they were put on dialysis and why they were put on dialysis. And, there seems to be no universal criteria for putting people on dialysis. So that's one of the kind of side issues that we're kind of looking at as well, to try to get some basic agreement on a consensus on what should be done. So I think we can say that's really true. And we can say that in Baltimore about type 2 diabetes as well, and certainly hypertension and so forth. So yes, and I would say in situations like this, it's very likely that there are people really on the edge, and there are people that probably died without any consultation with health facilities and without clear understanding of what happened. So I'm sure you're right.
Dr. Burnham, I have a question that's very off topic, but just to say hi, I'm Nick. We met last summer in the health course, and I absolutely loved your lecture.
Right, I recognize your name.
But have you been plugged in at all with the humanitarian crisis that's developing in Ukraine? And have you heard anything about how that NGOs and the international community is going to be able to start providing aid in Ukraine, or is the situation too unstable still right now?
Yeah, so that's a very good question. So Paul Spiegel from our center has been recruited by UNHCR to manage all the health services for the refugees coming into Poland and Hungary, and I think perhaps Moldova as well. So we can do something for the 3 million people that are coming across the border. Now, all of these countries have universal health coverage or universal health care. And so whenever you're dealing with a crisis like that, if you have universal health care in place, it's much easier to deal with these issues. So this is not something the US could do easily, but these countries can manage that fairly easily. And there's as you've seen already, a huge amount of goodwill in Europe for the Ukrainians who, in that period of time of independence from the Soviet Union, have really transitioned from being a Eastern Slavic nation to being more or less, at least intellectually and a large extent of economy, integrated with Europe. So there's a lot of that. But inside Ukraine, this is a real disaster. And I don't think anybody is trying to do anything as far as an external organization other than providing supplies and equipment and those kind of things. And you read about various groups that are sending in basic medical supplies, antibiotics, and other things, which, you know, run a gamut of danger when they're going. So I think that's what we're seeing now. And a lot of the Ukrainian medical staff have remained behind. So, you know, we know Russians love to bomb hospitals, and they're going to do that. And I think what we'll see in the future is what we see in Northwest Syria is hospitals move into the basement, or they move into caves, or they move out of sight, out of the range of Russian weapons. But one of the things that I really worry about, since there's a number of evil things happening inside the country, with including recruiting mercenaries, and if you followed the history of the Wagner group, they're a really thuggish mercenary group from Russia. And what we see in Syria is we see hit squads going out, particularly to target medical workers. And I'm concerned that we'll see that in the Ukraine as well. So that's kind of a roundabout answer by saying I don't think there's much at the moment, but I don't know for sure. Okay, Nick, have I successfully evaded your question? All right.
Well, we've reached the end of the hour, and I just want to thank you again, Dr. Burnham. You've given us lots to think about. It was a real pleasure, and we certainly hope to see you again over in our Center for Global Emergency Care. So keep an eye out for future invites, because this has been a great experience. And I just want to thank the participants, everyone who attended. And if there's no further comments or questions, I want to wish everyone a great week. And Dr. Burnham, have a safe trip.
All right. Thank you very much. All right. So goodbye to everyone.
Bye, everyone.